Now I have the esteemed pleasure of introducing our next two truly incredible speakers. Ms. Kathleen Farrell is the Senior Program Manager for Clinical Research with the National Epilepsy Foundation, joining us all the way from our national office in the Washington, D.C. area. And Dr. Jason Schwalb, who we are honored to have as one of our esteemed professional advisors, and is the neurosurgeon with Henry Ford's Comprehensive Epilepsy Program. This session is generously sponsored by Henry Ford Comprehensive Epilepsy Program. I know our speakers have a lot of ground to cover, so I'll let them get started on the topic of epilepsy research, accelerating new therapies. Thank you.
Good morning. I have slides. Let me just. Oops. Is there a clicker? I'll just use the. That's fine. No, I can use the keyboard. Good morning. I'm Dr. Kathleen Farrell. I'm the Director of Clinical Research at the Epilepsy Foundation National Office near Washington, D.C. I'm really excited to be here. I'm a little nervous because I have such an incredible speaker and Joyce to follow, but I'm really excited to lay out some information on the epilepsy landscape, the program at the Epilepsy Foundation for research, and ways that you and your loved ones can get involved in this fight for epilepsy, fight against epilepsy for no seizures and no side effects. So there really is an unmet need in the population with epilepsy. 30% of people do not have seizure control, despite over the last 15 years, since the mid-1990s, about 15 new drugs and devices have entered the market. Some of them on the slide that you'll see here, including the deep brain stimulator, the trigeminal nerve stimulator devices, those are currently undergoing clinical trials in the United States. They're approved in the EU, but we're looking to bring them to the market here. But despite these increased options, a lot of people are still not finding seizure control, and that's not acceptable. And historically, epilepsy, compared with other disease areas like Parkinson's, Alzheimer's, we don't have a lot of nonprofit support in the past. I've put Parkinson's against epilepsy here, and you'll see that while Parkinson's nonprofits have historically contributed up to 36% of their funding, epilepsy, on the other hand, has sometimes only contributed about 5%. And the Epilepsy Foundation, along with our chapters and affiliates, are looking to change that. So the Epilepsy Foundation, as many of you will know, is a 501c3 nonprofit organization, and we're made up of affiliates and chapters across the United States, including the EF Michigan here today. So we are looking to prevent, control, and cure epilepsy through multiple channels. These channels include community service, public education, federal and local advocacy, and support of research for new therapies and treatments. We're looking to cover the whole spectrum of research, and the spectrum of research goes all the way from basic research, asking fundamental questions of how things work, through drug development. Preclinical research is also known as kind of considered animal model research, and then that goes to clinical trials, which are in human patients. We also go through then post-approval research. Once a drug is approved, how does that, we need to follow that through. So we look at FDA and post-approval research as well. And our EF research program is looking to do that through 3 work streams: innovation, engagement, and support of next generation scientists. So first I'll talk about the innovation work stream, and you'll see on my slide I have a light bulb in green, so that signals our innovation work stream. We're pushing forward new ideas for epilepsy care and cures, and we're doing that through promoting partnerships among researchers, clinical centers, clinicians, providing financial support and funding for grants, fostering innovation and entrepreneurship, which I'll talk a little bit more about, and providing visibility to treatments and development. For example, here, Dr. Goda, a PhD, and he was the founder of Visualaze, said that it was validation by the Epilepsy Therapy Project of the Foundation that vetted their project and proved that they had a worthwhile pursuit and they've been a significant factor in our rapid progress and expansion into new centers. Now, Visualase is the laser thermal ablation device, and we supported them from the foundation in 2011. They were later acquired by Medtronic. Dr. Oren Davinsky is based at NYU in New York, and he said that receiving the Epilepsy Foundation's Innovation Seal of Excellence was what provided critical seed funding for their open-label study for cannabidiol, Epidiolex. And it was the positive results from that study that convinced GW Pharmaceuticals to proceed with randomized control trials. So the Epilepsy Foundation has always supported the need for research in cannabidiol. And a way that we provide a platform to give visibility for these drugs and devices in development is at our biannual pipeline conference. This takes place every 2 years in San Francisco, California, and it's a 3-day event. On Thursday and Friday of the events, the companies and research groups have the opportunity to share what they have in their preclinical and clinical device stages, drug and device stages. And then on Saturday is our community day. Saturday, we look to incorporate patients, families, advocates to come together to talk with experts, hear presentations on what's new in epilepsy. There's a lot of time for networking. It's similar to an event like this amazing event. So our next event is coming up in February of 2018, and we'd love to see you there. There's more information on our pipeline page on epilepsy.com. Another way that we support innovation is through our SUDEP Innocentive Biomarker Challenge. SUDEP is sudden unexpected death in an epilepsy patient, and it affects 1 in 1,000 epilepsy patients per year. We lose 1 in 1,000 every year to SUDEP. And when seizures are not controlled, the risk increases to 1 in 150. That risk is unacceptable, and it's terrifying. So what we're doing is we've decided to raise the awareness of SUDEP. We know that practitioners are not great at mentioning this. Yes, it's a tough subject to cover with people and their families, but people and families unanimously, what we hear is that they want to know the risk. So we're generating ways to share news and awareness about SUDEP, and as well on the harder science side, we're looking to develop a valid human biomarker to predict SUDEP or seizures that are life-threatening, those that compromise cardiac or respiratory function. And a biomarker is something like an EEG, a blood test, the HbA1c for diabetes is a great example, and we want something like that for epilepsy, for SUDEP. So over the course of 4 challenges, we're currently in our 4th and final challenge. We've put over $1 million in the 4th challenge alone, so more than that over the course of 4, into developing a predictive biomarker. We're entering our final milestone, which is a race to the finish, and I would encourage, I'm happy to share this slide set, but I'm happy for you to take a screenshot of this slide in particular. Citizen scientists, as well as established researchers, are welcome to apply. We're looking for people to be thinking outside of the box. We're at a critical need point to solve the SUDEP puzzle, and anyone could be the person to get to the answer. So it is a race to the finish between now and October 10th, 2020. Our newest innovation venture is the Epilepsy Innovation Institute, and it's something that we're really, really excited about. It is an innovation incubator, and we're willing to take on high-risk, high-reward projects. The projects have to be people-centric, impactful, boldly innovative, multidisciplinary, and knowledge-creating. And the steps are as follows. First, a topic is selected by a community survey, and I'm going to talk about our current project now. Next, a challenge is defined by experts across many fields. Funding is provided at $1 million per year for up to 3 years, and mentorship is provided across all platform and disciplines. For our first challenge in 2016, we reached out to our community to find out what was most important to them, what affects their life with epilepsy the most, what affects their loved one's life with epilepsy the most. We received over 1,000 responses and at least 1 response from someone in every state. And the overall feedback we got was unpredictability. I can't plan my day. I can't plan my week. I don't know if it's a good night to go out to dinner with my friends or take a vacation next month. unpredictability really affects every aspect of people who are living with epilepsy and their caregivers and their friends and family. It affects everyone. And therefore, we are going to be like a dog with a bone with this. Our first project challenge is the My Seizure Gauge. We're looking to create an early warning seizure risk assessment system. So I would liken this to a weather forecast. It mightn't be possible to say 100% at 12 o'clock it's going to rain, but we might be able to say it's not going to rain today. You'd be okay, to go outside today without your umbrella. You might be okay, and we're going to see how far we can push this boundary. Can we push this to days, weeks, months as the science progresses? So I'm really excited about this, and I hope to be able to share information as this develops in the near future. Now I'd like to move on to our engagement work stream. And you'll see the hand-holding purple symbol on the top of these slides, just to keep a bookmark of where we are. We spearhead at the Epilepsy Foundation the Rare Epilepsy Network. And this is a collaboration between Epilepsy Foundation, Columbia University in New York, and the Research Triangle Institute in North Carolina. We're made up of over 30 rare epilepsy organizations. And we are a registry that anyone with a rare epilepsy can enroll in. Patients can enroll themselves, caregivers can enroll their loved one. And to date, over 1,300 people have enrolled, and we're still growing. Our goal for the REN is to support patient-centered drug and device development. And our short-term priorities are to analyze caregiver priorities and perspectives. We're also looking to establish patient-reported outcome measures and validate the REN data. In the longer term, what we'd like to do is to create a clinical trials and studies network for pragmatic clinical trial design. We'd also like to create a priority list of treatment recommendations based on genetic signatures for epilepsies that are caused by genetic mutations. And we'd also like to identify populations that make sense being grouped together for clinical trials and drug development. The rare epilepsies are rare and understudied and underrecognized, and we share the common goal to understand etiology, natural history, and seek improvements for diagnosis, treatment, and quality of life. Next is the Research Roundtable. And the Research Roundtable, we're entering our third year of this initiative. What we do is we convene stakeholders, all stakeholders, patients and advocates, researchers, clinicians, industry partners, and regulators. We've always had involvement from the FDA here in the United States, as well as the EMA, who are the European equivalent of the FDA. And we convene once a year to discuss roadblocks in clinical trials and drug development in epilepsy. In 2016, we focused on reducing placebo exposure in clinical trials. A placebo exposure arm is when patients are participating in a clinical trial and remain on the medications that they're on currently, but no matter what happens with their seizures during that period, whether their seizures get worse or not, they can't increase or decrease the dose of the anti-epileptic drug they're taking. And that rightfully is scary and makes a lot of people uncomfortable. So we convened that group, this large group of all different perspectives, to see what we could do to reconfigure trial design to reduce the placebo exposure. We recently published our article in the journal Neurology, and I'm always happy to share my contact information and share that paper with you. But the FDA and other regulators and industry partners were really excited to explore this area. In 2017, we pursued pediatric drug development. And in our meeting coming up in 2018, we'll be looking at populations and endpoints in epilepsy trials. A lot of times in epilepsy trials, seizure count is the main outcome measure. Did your seizures go up or did your seizures go down? But there's so much more, that counts when you're an epilepsy patient, what your quality of life is, what your, within your seizure count, what is the seizure burden? So we're looking to explore that, and again, I'm looking forward to sharing updates after this coming meeting. Our newest engagement tool is the Clinical Trials Portal, and this is where we're looking to connect people with clinical trials that might suit them. We surveyed people in our community, about 80% of people said they would be willing to participate in a clinical trial or observational study. An observational study is when you don't necessarily do anything different in your day-to-day life, but you're tracking your seizures, you're tracking your day-to-day activities. And it's actually very helpful to researchers to develop drugs and devices based on observational studies. 80% of people said they would be interested in participating, but almost that same proportion, 80%, said they never had because their primary practitioner, their neurologist, their epileptologist had never told them of availability of clinical trials that might work for them. So we decided to convene a portal, and it's available through epilepsy.com, which will show people what observational studies, clinical trials are available in their area by their seizure type or syndrome. And looking at, people's experiences in participating in these, and it's a scary prospect when you don't know what goes into a trial. So on the portal, there's a tool that teaches you the steps of participation, and for each trial, we break down what your participation will look like. And looking back at people's participation, almost 85% of people who have participated in an epilepsy clinical trial say they would do so again. Our third and final work stream is supporting next generation scientists. And for this, we work with the American Epilepsy Society, which is kind of the professional arm of the epilepsy world. Since 2007, the Epilepsy Foundation has invested almost $13 million in our workforce. Junior investigators, postdoctoral fellows, clinical fellows, graduate students, and all the way down to college students. We find that when we start working with professionals in their educational stages and early training, they tend to stay in the epilepsy area, and that's what we want. The Institute of Medicine, the American Academy of Neurology, and the National Institutes of Health have all highlighted the need for epileptologists and people focused in epilepsy and research. The average waiting time for a new epilepsy patient to be evaluated is 3 to 6 weeks. That's a long time when you don't know what's going on, when you feel alone in the ocean. Children's hospitals report vacancies of up to a year for child neurologists. And there's also, according to the NIH, and we know it, it's clear, there's a real lack for epilepsy researchers. So we try to get people early in their professional and educational lives, and hopefully they'll stick with us. And you'll see that we've supported our workforce all over the country. Since 2007, we've invested almost $25 million in research grants. And our research knows no bounds. We support all over the country and all over the world. Wherever the research and wherever the science is king, we will go. We want to invest in research. Specifically here in Michigan, we've invested almost $500,000 in the developing workforce and developing diagnostic tools. I've put up some quotes from Dr. Calhoun and Dr. Auerbach, both here in Michigan. I believe they're both at University of Michigan and Northwestern. And they said that the grant money that we provided to them, the support through their pre-doctoral and postdoctoral training, really helped keep them in the epilepsy field and really supported the work they were doing. Most importantly, the work that the Epilepsy Foundation is able to do is because of you. We can only do it with your participation. So some of the ways, it's not only research. I've talked about a lot of the research ways that you can participate. Join us at the 2018 Pipeline Conference and Community Day in February in California. Enroll in the Rare Epilepsy Network, or let people know in your community who you know might be dealing with a rare epilepsy of its availability, and tell them to enroll. It's something that they can do from wherever they are, from their computer, and at their own convenience. Consider a clinical trial or observational study. And then the Epilepsy Foundation is fantastic in the amount of advocacy and awareness opportunities it has. You can make your voice heard in public policy matters. Every year at our national walk, which takes place on the National Mall in Washington, D.C., around that time of year, the Epilepsy Foundation visits the Hill with everyone who wants to participate. You can visit your local representatives, your congresspeople, and fight for your cause, raise awareness, make noise about epilepsy. You can participate at our national walk, and I'd like to save the date for our next walk, which is taking place April 14th. And I know Michigan and other chapters and affiliates of the foundation have their own walks. Get involved, show up, wear your t-shirt, make noise. Take part in a community action network. Lemonade for Livy, Kids Crew is for children. It's an amazing opportunity to raise education, participation, get people involved, get children involved. As well as social media. Social media is a major platform. It's, how our world communicates today. The Epilepsy Foundation really recently, only about last week, so I don't have a slide on this, partnered with CURE, which is Citizens United for Research in Epilepsy. A gentleman who is in the Hamilton production in Chicago, his daughter has a rare epilepsy, infantile spasms, and he's partnered with us to say, we need awareness. We need to be like Parkinson's and Alzheimer's and MS on the national stage, the international stage. And we have the power to do it. We have the numbers to do it. So he's helped us start a viral campaign, which what we hope will be a viral campaign of My Shot at Epilepsy. And it's going to be a picture. I feel really goofy doing this now. But like this, and you're going to hashtag it My Shot at Epilepsy on Twitter, Facebook, across social media. So visit epilepsy.com, and I'm happy to answer any questions and provide, like I said, provide this PowerPoint, talk more with you after this. But it's such an honor to work with you and work for you as part of the Epilepsy Foundation. I'm delighted to be here and honored to be here on Veterans Day. So I'm not sure if my co-presenter is going to present, or should I take Q&A? I'm happy to take questions now. We'll do it after. Okay. Thank you very much.
Good morning. Got it. GPU ready to sleep. Okay, cool. So thank you to the organizers for asking me to talk about some of our research in this clinical trial that we're proud to be asked to be involved with. So I'm going to talk to you a little bit about the SLATE trial, but before I get into sort of the nitty-gritty of that, I wanted to talk about just sort of why we're doing this. These are my disclosures. So, I wanted to point out, obviously, this is known by many of you, but epilepsy is bad. And obviously, epilepsy has a major effects on people's lives, especially if they're having uncontrolled seizures. So people with epilepsy have a decreased length of life, especially if it's a known cause. There's impaired quality of life. Many of that is because of social stigma. But people with epilepsy are less likely to hold a job, are more likely to commit suicide, and feel stigmatized. And we have to work hard, as Joyce Bender spoke, about changing our society to reduce that. But another way to help with that is to reduce seizures. And one of the scary things is the high rate of accidental death. So 6 to 20% of people with epilepsy die from having a seizure and injuring themselves or drowning them or ending up drowned because of not being able to control what's going on with their body. And that's about twice the risk of the general population. And that is separate from something Dr. Farrell mentioned, which is SUDEP, or sudden unexplained death of epilepsy. Sudden unexplained death in epilepsy is, as indicated by the name, unexplained. So this rubric, this does not count people who have a seizure and die from status epilepticus or die from a trauma or from drowning. Fortunately, it's fairly rare in children and in many people with epilepsy, but for people who are having more than 3 generalized tonic-clonic seizures a year, it's actually fairly common. And it's about 1.8% per year, and that's quite high when you're talking about someone who's young in their 20s or 30s. So between SUDEP and non-SUDEP epilepsy-related death, there's about a 10% mortality rate per decade in adults, with even just as few as 1 generalized tonic-clonic seizure a year. That's high. So how do we get control of seizures? this is a famous paper that was actually published way back in 2000. Unfortunately, with all the drugs, the statistics haven't really changed. So about 47% of people become seizure-free with the first drug. You get about another 13% with the second appropriately chosen drug at appropriate doses. But once you're getting to third drug or multiple drugs, the likelihood of being seizure-free, even under expert care from an expert epileptologist, is only about 4%. So, to my mind, surgery equals hope. And one of the things we do, or so one of the most common operations that we've been doing for 70 years or so, is temporal resections or open brain surgery for temporal lobe epilepsy. And if that is, of course, if the seizures are coming from that area of the brain. And this can be tailored based on the preoperative workup. And this is much better than medical therapy. So this is actually an old slide from 2001 from a paper in the New England Journal. And you can see that if you're looking at percentage of patients without seizures impairing awareness, which is usually what we're looking at, that's what's called the Engel class or Engel 1 in the literature. The likelihood of being seizure-free in the surgical group in this trial was 58%. In the medical group, it was actually a little better than 4%. It was at 8%. But there's no question that surgery is much, much better than continued ineffective medical therapy. And not only is there decreased seizures, but there's significant improvement in quality of life. So to me, surgery is hope of seizure freedom. One of the problems is that we have this really effective therapy in appropriately chosen patients that's incredibly underutilized. So this is a slide from the Institute of Medicine actually published this large report. It's basically a book. You can download it. It's a PDF in 2012. So there are about 1 million people in the United States with drug-resistant epilepsy who are still having seizures in spite of appropriate medication. And the epidemiologic data suggests that there's somewhere between 100 and 200,000 people in the U.S. who are surgical candidates, and yet we only do about 4,000 surgeries in the U.S. So there's this huge disconnect. We've got this therapy that we've known for at least 20 years that really works well, or at least 15 years that we know really works well, but people don't want it, or people aren't getting directed towards it. So if you're looking at patients with temporal lobe epilepsy and with surgery, you can significantly reduce not just seizures, but also the risk of SUDEP, the risk of accidental death associated with epilepsy, by about 60% of the time. Now, similarly, if you have someone who has breast cancer with a 2-centimeter nodule, without lymph nodes, without metastases, chemotherapy reduces your mortality by 10%. And yet, if a patient had breast cancer and wasn't offered chemotherapy, that would be an uproar. Any oncologist who did not offer a patient chemotherapy for a 10% reduction in death would be properly vilified and sued for malpractice. And yet we tolerate, why are we tolerating this for epilepsy for the same risk reduction, for a 10% reduction in death per decade? It's really not acceptable. So this begs the question, why do people with epilepsy and their neurologists often not consider surgery? And I think some of it is that people are not rational. So I'm a big fan of Daniel Kahneman, who's a Nobel laureate in economics, who basically, with Adam Smith and prior to Kahneman and Tversky's work, people sort of viewed economics through considering people as rational actors. And the reality is that people are not rational actors. So this is a great book. Michael Lewis, who wrote Moneyball and The Big Short, his most recent book is about Kahneman and Tversky. It's called The Undoing Project, which is great. I'm about halfway through it. So people are not rational actors. So part of it may be that the seizures or epilepsy looks benign when it starts, I think a lot of it, frankly, is a knowledge gap, that there's inappropriate optimism about seizure reduction. So if you come in and you're having seizures every week and you get placed on medications and now you're only having 2 or 3 tonic-clonic seizures a year, that is a success. You've been reduced in your seizure frequency by 80%. But the reality is that's not good enough. Because if you want to reduce your death rate from epilepsy, you got to get under, you really need to be seizure-free, or hopefully at least free of generalized tonic-clonic seizures. Human beings are really terrible at assessing risk. And then, as we heard, there probably are not enough specialists, and it's hard to get in to see those specialists. And then there's understandable fear of open brain surgery. So one of the problems with human beings is we are generally quite risk averse. So there's loss aversion bias. So you can do gambling experiments in psychology where people are shown quite consistently to give up a $2 gain to avoid a $1 loss. And I think a lot of it, frankly, is status quo bias, is we get used to what we were used to, even when it stinks. And doctors and patients and parents get used to terrible epilepsy. So one of the examples of this is actually what happened after 9/11. And this is a slide of Orrin Davinsky's, who was mentioned before. So obviously there were 4 airplanes that were hijacked, and almost 3,000 Americans died. And over the next year, there is a loss of trust in the airline industry. And I think a lot of it is also, you feel like you're in more control if you're behind the wheel than if you're on a plane and you're trapped, and there might be a terrorist or there might be some other problem. And we know in the year following 9/11, we had an increase in death rate on American roads of about 1,600 Americans, because more people were driving and weren't flying as much, and flying is much safer. So if you have 4 flights a month and one hijacked plane a month, and that goes down, still your risk of death is about 1.5 million, and yet we know that every time, just especially living in Michigan and car country, your risk of dying in a motor vehicle accident is about 1 in 7,000. So we are really bad at assessing risk. So how do we improve this sorry state of affairs? One is by giving talks. So better education of clinicians and patients, and understanding patient preferences is really important. And then we frankly have to do a better job of predicting quite early who will and who won't do well with surgery. And then I think a large part of it is going to be making it less scary. So improve technology with reduced risks and discomfort. And so I'm really proud that we were chosen as one of 15 centers in the United States to participate in this trial of essentially doing a temporal lobectomy through a 3-millimeter burr hole, or twist drill hole. So this is basically taking out this part of the brain that's causing seizures and frankly doesn't work well anyway. Instead of doing a big open surgery where we take off a window of bone and have to frankly take out brain to get to the area that's involved, we have this huge advance. It's not just the laser. The really big advance is new MRI sequences. So we have these new MRI sequences where you can look at the temperature of every pixel on a slice in real time. So that allows you to put the laser in, heat it up, and monitor the temperature of the tissue, make sure it's getting high enough that you're destroying that tissue, and make sure other areas that you don't want to damage that are important are fine. And we actually set it up so that, let's say it gets close to the brainstem above 40 degrees C or 45 degrees C, it'll just stop. And I think that my hope is that this will reduce the fear of surgery. And this is an example of one of our cases with one of these heat maps and looking at the ablation. And the patients go home the next day. The FDA cleared the visualized device to, quote, necrotize or coagulate soft tissue through thermal therapy and neurosurgery, and multiple additional named specialties under MRI guidance. There are a couple different companies that make these. The trial that we are involved with is with Medtronic, who now owns Visual Ace. And this is sort of what it looks like pre-ablation with this tiny, it's less than 2 millimeter diameter laser fiber. And then there's an algorithm that develops a real-time damage model. And then on the left, you can see here, we've given enhancement, enhancing contrast, and you can see the outline of the area that's been damaged. And this is one of our patients that we did before we started in the trial, and you can see that the rest of the brain looks really normal except for this area right here. So it's quite focal, quite specific. So the advantages are theoretically this should lead to decreased risk of stroke and visual field cuts because it's much less invasive. It may reduce the fear of surgery. It definitely reduces length of stay from about 3 or 4 days to 1. Decreased discomfort. Patients are getting back to work and going back to their lives quite quickly. And the reality is if it doesn't work, we can do the old-fashioned open operation, or we can repeat it. So we have multiple options. There are some neuropsychological advantages of laser ablation. In patients for temporal lobectomy, the question is, we want to get rid of the seizures, but we don't want to have the patient lose their muchness. So that's important, and we think that the risks of to the patient's psyche and the patient's neurological function seems to be less, at least on some of the preliminary evidence, compared to open surgery, whether it's on the dominant side of the brain or the non-dominant side of the brain. And in fact, I've talked to some leading epilepsy surgeons, including Dr. Spencer, who I trained with as a medical student, who would not operate on a patient with intact memory in their dominant temporal lobe. We don't offer surgery of those because we're concerned about hurting people's muchness, and yet this may be an option for those patients, and they're actually included in the trial. The disadvantages, sometimes it's really hard to get a good trajectory. It may be difficult if the seizures are coming from somewhere else other than the temporal lobe. So this is the study. Medtronic is the sponsor, and it's basically a safety study. It's not randomized. Everyone who gets enrolled gets the therapy, and we are currently at 15 centers, of which Henry Ford is one. And we get consent and enrollment, and then the patient gets set follow-up, has the procedure, and then gets set follow-up for a year, including neuropsychological testing. This is for adults only, so 18 or older, and it's basically patients where everything points to the mesial temporal lobe on one side being the culprit, being the cause. So the MRI suggests that, the neuropsych suggests that, all the EEGs, the video EEGs all suggest that it points to one mesial temporal lobe. So there's a safety endpoint, and then there's an efficacy endpoint. If the patient has a vagus nerve stimulator, they must have, basically, some of the inclusion criteria are making sure the patient is on stable therapy. It may be stable VNS therapy, that may be stable medication therapy to really be able to assess the effect. And the way the trial is designed is you want to be able to read the signal. So I think there's a role for this therapy and for temporal lobectomy for people who are having less than one seizure a month. But if the patient's only having a few seizures a year, you're not going to see the outcome unless you have a decent signal to noise. So that's why Medtronic and the people who designed this study have said that to be involved in the study, you need to have at least one complex partial or secondarily generalized seizure a month. Video EEG all points to one temporal lobe. The MRI is consistent. One of the issues is that the patients are on stable seizure medications and VNS settings for a year afterwards, because otherwise you don't know if it works or if it's the changes that you made in medications. And the patient needs to be willing and able to comply with the protocol requirements. In terms of exclusion, if the patient is not neuropsychologically able to participate in consent, if they're pregnant or intend to become pregnant during the course of the study, if they can't have an MRI for some reason, if they have some sort of progressive neurologic disease like multiple sclerosis or a brain tumor, if they've had prior brain surgery for epilepsy, or if there are basically signs of the seizures coming from somewhere else other than that one mesial temporal lobe. They have to have an IQ over 70, not have progressive neurologic deficits, and sometimes patients with epilepsy have electrographic seizures and also have psychogenic non-epileptic seizures. Again, I think that there's definitely a role for epilepsy surgery, including laser ablation, for those patients to get rid of the seizures that put people at risk of SUDEP and risk of trauma-related injury. But for the sake of the trial, if you're looking at seizure frequency, it's got to be a pretty pure population. And you have to be able to get the contrast, so you can't be allergic to gadolinium, which is fortunately rare. So one thing I would say is that this is a trial. It is supported, and that's great. Patients who do well, who are enrolled in trials, tend to do better because, frankly, their docs and research coordinators are paying more attention to them and are all over them. But patients can still be treated outside the trial based on the wording on the FDA approval. And we've had patients that have come to us already. We've been doing this trial for almost a year now, where they decide they don't want to do the follow-up or they don't quite qualify, who have yet gone on to have laser ablation and have done fine. So thank you. So this is a large group of people, and I want to thank the other clinicians and support staff at the Henry Ford Comprehensive Epilepsy Program. And the one person who was out that day, probably because she was in the operating room, was my partner, Ellen Ayer. So I'd like to thank her as well. Thanks. So we have about 15 minutes for questions.
You have to hold it? Okay. Gotta have somebody hold the mic for me. Can't do it myself. Okay, I have questions for both of you, actually. Kathleen, I'm no biochemist, right? So why first looking for a biomarker for SUDEP? I mean, why just SUDEP and not maybe some other type of epilepsy?
So that's a really great question. Is this on? That's a really great question. And I suppose the thing that makes epilepsy so individual compared to other neurological disorders and other diseases in general is that there are so many types of epilepsy. There are so many factors that go into a diagnosis. Some are genetically based, some are not, some are post-traumatic. They appear later in life, they appear earlier in life, and they manifest very, very differently across that spectrum. So while we are always looking for a cure for all epilepsy, we have to start with what's tangible, what's possible. And SUDEP is a big enough risk that we thought it's extremely worthy of trying to develop a biomarker. And our hope is that a biomarker that we're able to establish for SUDEP could in some way develop then down the line and be applied to epilepsy in general and specialize somehow for the different epilepsies. So that's our mind is there. A biomarker is definitely needed for epilepsy, and better diagnostic evaluations for epilepsy is needed. But SUDEP is something that we went after because the risk is there, and we can't afford to lose 1 in 150 people who don't have seizure control every year.
This question relates to the SLATE trial. I wondered if you see in the future it being used outside of temporal lobe epilepsy, and then secondly, why is one of the exclusion criteria prior brain surgery or epilepsy surgery?
So I think, yeah, so there are some groups that are doing laser ablation for extratemporal epilepsy. For the SLATE trial, it's sort of an ideal area, but we've definitely looked at patients where we've done intracranial monitoring and you find something focal and can place on laser fiber and do the ablation. So I think it's very feasible. In terms of why patients with prior surgery are excluded, I think that when the trial was designed, it was basically it's always a question. You want to leave it open to maximize your recruitment, but you also want to have a fairly homogeneous group to be able to look at the effects. And if you have a few patients that are different, then it can change your results, and you can get significant outliers. So I think that in our practice, we are offering patients laser ablation outside the trial. So I wouldn't be discouraged if you have had prior surgery from considering additional therapies if you don't have good seizure control. But the design of the trial is basically to try and compare laser ablation to a first go-around on anterior temporal lobectomy. So the question was how many centers in Michigan are performing laser ablation. We are the only ones doing it in the trial. We have the longest history. I'm not sure if anyone else is doing it right now. There may be maybe one other center on the west side of the state, but I'm not sure if they are.
Kathleen, just a quick question. Are there any research looking at the use of wearables with seizure detection, being able to help patients identify when a seizure might be coming on, either by heart rate, respiratory rate, something like that?
So the question, in case you didn't hear at the beginning, was whether any research is being done into wearables. And that is one of the really big areas where the focus is in research. Wearables such as watches, bedding, clothing, other monitors. And I think with the advent of smartphones and cloud-compatible devices, that is being pursued heavily. Empatica worked with the Epilepsy Foundation very early in development of their smartwatch, which was one of the first wearable devices, seizure detection devices. So yeah, that is a really big area. I'm trying to think of specific groups, and none are coming to mind, but there are a few companies that are also working on devices for diagnostic purposes. We funded in our 2016 Shark Tank competition, which is a part of the Pipeline conference that I mentioned before. We hold every year at Pipeline, but also in the interceding years at the AED meeting in Miami. We hold a Shark Tank competition modeled on the Shark Tank, the show, which I had never seen until I was at Pipeline and saw this format. And we look for entrepreneurs to come forward with devices. Mainly devices is what we get at this competition that they have in development. And there's a company called Zito, who were a winner last year in 2016 they're revolutionizing the way that EEGs will be done. Devices for epilepsy are still kind of far behind where they are for other disease groups. And now with cloud compatibility and smart technology, watches, phones, things like that, there's a lot on the horizon to kind of bring the epilepsy detection devices, but also diagnostic devices out of the dark ages. They were promoting or previewing their device that they're working on. You were able to put on the headset. It looks like something developed by Apple. Really simple, really clean. Put it on, and people were able to see their EEG on the compatible iPad or device that they had there instantaneously. And they were looking at how they're doing quality control review at that time to look how compatible it was when compared to an in-hospital EEG. And I think the crossover was something like 92%. it was comparable to what you would get in a doctor's office or in a hospital. And this is still very early, but there are a lot of promising device development happenings going on.
I've been associated with epileptic people 75 years. I had an uncle that had it. We hired people at our job, and they've had it. And now I have an adopted granddaughter. She attempted suicide yesterday. She's in a psychiatric ward in Michigan. But this laser surgery, you say 18 and up. She's been to Cleveland Clinic, and they are now in a process of determining whether she should have open brain surgery, and they're giving her a 70% chance. Where do we go? Do we have a choice?
Yeah, I'm not sure that Cleveland Clinic is one of the sites. It's easy to find out. You can, and for anyone who wants to, look more into the trial and other sites, you can always go to the clinicaltrials.gov website and just search SLATE. I don't think CCF is a site. We'd be happy to look at her records and see what we could potentially do, and if it's appropriate or not. The fact that they're saying it's over 70% makes me suspect that her seizures may be coming from her temporal lobe, because the likelihood of success with extratemporal epilepsy is a little lower. It's usually 50 to 60%. We quote patients. So our booth is in the corner.
Okay. After the ablation surgery, are there any other neurological complications or problems that the patients experience?
So I can tell you in the few that we've done, we haven't seen any problems at all. I know there have been a couple patients where it hasn't worked the first time, and they've had to go back for a second laser ablation. There's actually part of the study design for the SLATE trial, the patient can have a second ablation even within that year or within 6 months or so. There has been one patient, I believe, who had a visual field cut, which is a known complication of the open surgery that was noticeable. We had one patient who had a slight visual field cut that was not particularly noticeable, and actually we had one patient who's fairly recent who has a little bit of double vision, and our hope is that that'll get better over the next month or two.
We have a 26-year-old son who was diagnosed at the age of 8 with simple partial epilepsy and has gone through 15 different medicines over the years, had the VNS put in back in April, has had some success with it, still having about 50 seizures a month. Do you see, and his seizures are deep in the middle of the left part of the brain. They can't really get too much more specific than that on all the diagnostics because they say it's just so centralized in the middle. Do you see the potential for this laser ablation in the future to be able to go to depths inside the brain?
Yeah, it's sort of ideal for depths in the brain. That being said, for patients with simple partial seizures, so for people who may not be, and frankly the terminology keeps changing, the difference between a simple partial seizure and a complex partial seizure is that there is loss of consciousness or loss of awareness in patients with complex partial seizures. And those are the ones that are dangerous, that lead to SUDEP and lead to some of these other problems. And those are the ones that frankly, patients with uncontrolled complex partial seizures, they end up, yes, one of the risks of surgery is problems with memory, but patients with uncontrolled complex partial seizures, especially if it's temporal lobe, end up losing short-term memory over time as well. That being said, if your son truly has simple partial seizures, I know those are distressing. We tend not to offer surgery for those because they're not, because they're not quite as dangerous, even though they can be stigmatizing. It's generally, we generally at our center don't recommend invasive brain surgery for that. Because frankly, you know, when I showed those slides for temporal lobectomy, many of those patients still have simple partial seizures or have auras. So, you know, if I take a patient who's having 2 or 3 complex partial seizures a year, and I get them so they're just having auras, that's a home run for me. Yeah.
Thank you. Going back to wearables and the like, I'm 18. I have juvenile myoclonic epilepsy. I don't know. I think I speak for a lot of people when I say that I don't want to have to depend on a smart device to be aware of when my seizures are going to come. When I first was aware that I had this disease, you know, I thought I was so certain that I could tell when my grand mal seizures were coming on. I was totally wrong. I live in a house with 5 other people, and pretty much anytime I drop a bar of soap, you know, I have 5 people asking me if I'm okay. So that's all damn day. So basically my question is, have you been able to look into any wearables, any sort of device, you know, even like that you put in your body that can give you a sense of when your seizures are coming on?
So I can't speak to any specific implantable devices. I mean, I've heard the concept. I know that there are groups that are trying to pursue that, but not really on the Epilepsy Foundation's radar that I know of right now. But I do, you know, your point is a great one, that people don't want to rely on an extra bit to their life that you need to carry around, or you need to always make sure that you have with you. So your point is really well taken, really well made. I'm not sure if Dr. Schwalb knows of implantables.
Yeah, the only implantable that I know that sort of works like that is the vagus nerve stimulator, and may need to talk to the LivaNova rep, which is what they now call Cyberonics. So their device is set so that if there's a sudden jump in heart rate, not sort of a steady increase like, you know, you're going out for a run, your heart rate goes up, but a sudden jump in heart rate, it can detect that and deliver an extra electrical signal to the vagus nerve. But I don't believe that in any way comes up on your phone or anything like that can notify you that, you know, that you're about to have a seizure. And that, I think, is a little late in the game. It's not going to give you, you know, half-hour warning. It's going to be basically as the seizure starts. That's my understanding, unless the LivaNova rep wants to disabuse me of that.
Dr. Jason, on the laser ablation on your slides, it appeared that the patient had some type of deformity or malformation of the brain tissue in the area that you did the procedure on. Is that one of the focuses of the surgery, is just going in through the MRI saying, we know this is the area, it's deformed, we're going to ablaze it? Or could, since the focal area, like in our son, doesn't have a brain deformity or brain malformation on it, could he be a candidate as he gets older in life to have that focal area ablaze, since there is no malformity where his focal area is?
Yeah, so in patients with mesial temporal sclerosis, the mesial temporal lobe looks sclerotic most of the time. But in some patients it doesn't, even though the seizures are coming from that area. There is some controversy about the likelihood of success, and I think, you know, for the trial design, they wanted to maximize the likelihood of success from the therapy, but certainly, you know, we do laser ablation and we do temporal lobectomies for patients where there isn't an obvious abnormality in the mesial temporal lobe, but all other evidence points to that area as the culprit. So yes.
I've had seizures since I was 9. I'm 45 right now. I've had many medications, 2 brain operations, and the vagus nerve stimulator. Nothing's worked. So what would you suggest? What can I do?
Yeah, so that's hard, and frankly, you know, there are patients that we cannot help, you know, even with all our surgical tools, be it open or laser or NeuroPace or, you know, any of the number of different surgical tools. We do have advances in some of our other technology in trying to figure out where the seizures are coming from, including doing repeat intracranial monitoring with tiny little electrodes that are much less risky than the old style big grids and strips that you require a big open operation for. I don't know who your treating epileptologist is, but we, but I think given the changes, if you haven't been seen or it's probably worth being reevaluated. Or at least having your chart looked at and your EEGs looked at.
Well, I'd like you all to join me in thanking Dr. Schwalb and Ms. Farrell for being here today. So much wonderful information. Thank you.